On behalf of PHA Canada, welcome to our webinar on pulmonary hypertension and sleep. I'd like to introduce our presenter for today, Dr. George Chandy, who's a respirologist at the Ottawa Hospital. He is responsible for providing specialized care and treatment for patients with lung-related conditions, and we're so happy he was able to put together this presentation for us. So over to you, Dr. Chandy.
Hello. Welcome to everyone who's on this webinar. It's always a bit strange talking when I can't see everyone's faces, but I don't really mind. That's okay. I just want to make sure that I can be heard clearly just because I hear crackling on my end.
You sound pretty clear.
Okay, very good. So, what we're going to try to review today is the impact of obstructive sleep apnea on pulmonary hypertension. And I wanted to broaden this out to allow for other sleep-related questions that people may have, particularly related to pulmonary hypertension, but in general, as you may be concerned about related to this issue. I practice pulmonary hypertension in Ottawa at the Ottawa Heart Institute. In addition, I'm involved helping run this sleep clinic at the Ottawa Hospital. And so I've been intimately involved in both of these fields for about 20 years and have done more talks than I can account for in both of these topics. So I feel very comfortable addressing any questions you have regarding these issues. But of course, I can't answer specific medical concerns that you have related to your own medical condition in the webinar. But any general questions, you should just feel very free to ask the questions. What I was thinking of doing was running this such that I would stop maybe twice throughout the presentation before the end to allow for people to have an opportunity to ask questions. And I'm going to insert those pauses where I'll be transitioning from one topic to the next, just so that I can make sure everyone's clear about what was being discussed before we proceed. Would that be okay for the conveners, or is that complicated?
That's fine if it works for you.
Great, super. So the main topic today is going to, be that of obstructive sleep apnea and the impact on pulmonary hypertension. But in order to talk about this, we have to understand what obstructive sleep apnea is and what the physiological manifestations are of that on the body. In other words, how does obstructive sleep apnea affect your heart, your lungs, your system in general? And how might that affect pulmonary hypertension? I'm not going to talk about pulmonary hypertension in any detail here because, first of all of you are relative experts in it. You have quite a decent knowledge in this, I think, in addition to the fact that that would just take away from our primary topic. I don't really have any direct disclosures related to this issue. Ooh, my slides are not advancing. Give me 1 second. See if this works. Oh, there we go. No direct disclosures related to this issue here. So the goals will be to discuss the pathophysiology, just understanding how sleep apnea affects the body. And I was going to comment on central obstructive and central sleep apnea because they're kind of both relevant. Review the cardiovascular and pulmonary hypertension interactions, the benefits of positive pressure therapy, which is the main treatment for sleep apnea. So first of all, what about the epidemiology of this disorder? And epidemiology just refers to how is this disorder distributed in the population and in what manner. So it's really interesting. You may reflect that everyone you know seems to be on a CPAP machine. It's almost like a conspiracy that so many people are on CPAP machines. It is a disorder of disturbing prevalence, but it's because in general, I'm not talking about pulmonary hypertension, but in general, it's a disorder related to weight. In fact, 90% of the attributable risk is related to weight. What that means is 90% of the cause of apnea is related to weight. 10% is related to oropharyngeal or from in the oropharynx, which is the mouth to the back of the throat into the throat, anatomy. The rest of it is all weight. So, as society has become heavier over the course of the last 30 years, let's say, the average BMI has increased for many reasons. It's increased, but it has increased. This weight not only goes to our belly, our hips, but is distributed throughout our body. So if we think about the average individual who at the age of 20 or 25 was relatively slim, perhaps more active, as one ages, knowing in your own life and people you know, we all tend to gain half a pound a year or a pound a year, depending on our circumstances. So after about 20 or 30 years, many people are about 20 or 30 pounds or 40 or 50 pounds heavier than they had been in their 20s. But it's actually even worse than that in a sense, because most of the gained weight for most people would be in fatty tissue, but our average body percentage fat also increases as we age. And that's part of the natural process of aging and related to numerous issues, including hormonal changes. So our baseline weight also is a higher fat percentage in addition to the weight that we gained. Now, that weight doesn't go where our muscle used to be. So, a football player with enormous pectoral muscles or biceps doesn't lose the muscle there and have fat replaced there. The muscle is lost from where muscle was, but fat goes to where fatty tissue goes to where fatty tissue goes. That's distributed throughout the body, but it would predominantly in most people be noted in the belly or the hips. Having said that, it goes to the arms, it goes to the calves, and most importantly, for the purpose of this conversation, it goes to the neck. The neck is relatively slim, and the breathing tube of the neck is very small. So it doesn't take much weight gain in the neck for the airway to be crowded. So if you just imagine if this is my tongue and that's the back of my throat, there's space to breathe through there. When you have sleep apnea, that space is kind of crowded a little bit and it closes off. So if one gains weight, it narrows the space there is to breathe. So that's kind of what happens. So you could just imagine over the course of time, as our population has on average had a higher BMI, there's a higher prevalence of sleep apnea. So it's not exactly a conspiracy that everyone's on a CPAP machine. We don't really have great Canadian accurate up-to-date data, but if we look at the US data, which is more thorough, it's instructive. If we consider that in Canada, about half the population is overweight and obese, and in the US, it's closer to two-thirds. The numbers are actually slightly higher than what I've noted here. And if you look in the US, the best data is probably the Wisconsin sleep study, and even this is 20 years old, demonstrating, I don't know, can you see my cursor here? Okay, I just want to make sure. Um, if you look at adults, and this slide is a little bit complicated when you look at it, but simpler than you would imagine. Basically, it's looking at age on the left here, and here it's looking at least mild or worse sleep apnea in women and men, and at moderate or worse sleep apnea in women and men. So about somewhere between 70 and 31% of men, at 17 and 31% of men, and 7 and 16% of women between ages of 35 and 30 and 59 have at least a mild degree of apnea. And in terms of severe apnea, it's somewhere between 6 and 11 and 4 and 5% of men, let's say, for 3 to 5% of women have moderate to severe apnea. So that those numbers are pretty high when you consider diabetes is nowhere near 17 to 31%. Hypertension is nowhere near that number. So it's a very prevalent disorder. And I will tell you that it's very difficult to do large cohort studies, but the numbers are even higher now. So the biggest risk factor, which is obesity, is a major factor, and that's contributed to the increase in prevalence. Other factors are oropharyngeal anatomy, craniopharyngeal anatomy. Retrognathia means the tongue is a little bit further back. If the tongue is further back, it collapses the airway. If the palate is narrow and high arched, there's less space. So the palate is of a certain shape. It's either going to be wide and not so tall, the top of the palate up at the top of the mouth, or it's going to be narrow and high arched. The problem is your tongue in there doesn't have space. So if it's narrow, there's no space for the tongue, so the tongue is pushed back. So people with a narrow, high arched palate tend to have their tongue pushed back. That's a risk for apnea as well. There are nasal factors which are minor. It's really not a major nasal issue. Although if you have large tonsils, that's certainly something that can give you apnea. You can also get apnea from in a hereditary aspect, in that some people just naturally, the way their genetics are, their airway's a little bit narrowed back. They're more prone to airway closure. People can also have large tongues. Oh, there we go. Macroglossia, large tongues, or large tonsillar issues or other issues which can cause apnea. So those are the risk factors of apnea. There are other systemic factors as well, different diagnoses. Some of these which you may not have heard of, acromegaly, where people have increased bone structure in the large bones in their arms, hands, head, feet, and that can cause crowding, hypothyroidism, um, polycystic ovarian syndrome, diabetes, Cushing's syndrome, and just heart failure in general, which is actually specifically relevant to our conversation, which we'll come back to. The clinical history of apnea involves symptoms which you're all quite familiar: snoring, witnessed apnea, so the spouse, often the wife, noticing the husband is stopping breathing in the middle of the night. Both of these two things occur because the tongue falls to the back of the throat. There's not much space to breathe. And as you're trying to draw the air in, the tissues rub against each other. And sometimes people stop breathing completely. As a consequence of this, sleeping is disrupted. You don't get into a deep stage of sleep and stay there. You get arousal. So you end up being tired in the daytime because you're not sleeping deeply. Because you're not ventilating well with bad sleep apnea, you're not getting rid of the carbon dioxide and bringing the oxygen as efficiently as possible. You can get headaches in the morning. That's called morning headaches, which can last for 30, 40 minutes, can be caused by sleep apnea. You can look like you're choking at night. That's stopping breathing. Frequent awakenings are common. Nocturia means the need to urinate at night. That is very common with sleep apnea. I'm not going to say universal, but very common. There are very few reasons why women need to wake up to urinate at night. Sometimes after a pregnancy or multiple pregnancies, many women have difficulty completely emptying their bladders. There can be other reasons, but not very many. For men, type 2 diabetes and prostate tend to be common ones, but even for men who don't have those conditions, sleep apnea is the most common one. And the reason is as follows. In the daytime, you may need to urinate about 3 times in an hour, let's say 2 or 3 times. You won't even think about it. At nighttime, as a young person in your 20s or 30s, you would probably never need to get up to go to the bathroom to urinate. But as we age, we notice this happen more. It could be for those other reasons, but commonly it's because the brain produces something called the antidiuretic hormone. This is produced by the brain, which prevents us from peeing at night. Essentially, it has the advantage of preventing the kidney from filtering more blood into urine, which in turn allows us to have a more sustained pattern of sleep over the course of the night without awakenings. That's a good evolutionary advantage, so you have a deeper sleep. Unfortunately, with uncontrolled sleep apnea, you experience the inhibition of the production of this hormone. So you do not produce the hormone, which prevents you from needing to pee at night, and therefore you wake up to pee 2 or 3 times a night. So it's very common. Interesting, when you treat sleep apnea, all of these symptoms just disappear. People can get GERD or reflux. Heartburn can happen. They can have a sore throat from snoring all night. In the daytime, they can have difficulty with memory, cognition, and difficulty concentrating. In fact, a lot of these symptoms on the right-hand side there that I mentioned are symptoms that any parent who has had a newborn baby would recall in the first 3 or 4 months, particularly. You're always feeling cranky and tired. You can't think straight. You forget things. It's because you're getting interrupted sleep. But that can happen for other reasons, such as sleep apnea as well. This is just a diagram which nicely describes what I was mimicking with my hand puppets here. Essentially, the tongue is here. In a normal person, and airflow goes through there. In someone who has sleep apnea, they can have complete closure of the airway because the tongue falls back, and that could be accentuated if it's naturally narrow or if there's a lot of fatty deposition from weight gain. You can also get what's called a hypopnea. That's sort of a minor apnea, which there's still a bit of airflow, but so there's not complete closure of the airway, but it's narrowed. So you might hear snoring, so air's still going, but it's still an impact on the body, and it involves the need to take a big breath in. What many of you would have been quite familiar with are these horrendous masks for sleep apnea. So this is the biggest negative in terms of treating sleep apnea, that people would often say, "Oh, I don't want to wear that mask." Well, fortunately, these Darth Vader masks are a little bit in history. There are modern masks which are far more svelte and more maybe easy to accommodate. Now, the truth is, interestingly, you might look at this mask this gentleman's wearing and say, "Oh, I want that one. It just looks nice and small." But, comfort is like with a mask is like a pair of boots. You can't look at a pair of boots when you go to Canadian Tire and decide which is going to be the most comfortable one. You got to try them on and decide once you've got them on. So sometimes this surprisingly is more comfortable because it just stays in place. There are many different masks. I just tried to pick the most horrendously looking one from the internet to stick on here. No one uses this mask I put up. So anyway, it's a lot more amenable to use. It's a lot more comfortable, easy to get used to these days than it used to be. So the whole idea with positive pressure in this cartoon-like diagram is there's air pressure coming through a tube from a machine through a mask interface, pushing through either the nasopharynx, like through the nose, or through the mouth, and it's stenting open the airway, using air pressure to keep the airway open. Much like a tire would be inflated when a tire in your car would be inflated. So it's just using air pressure to keep it open. There are other options. There are mandibular advancement devices, and this is just a side cut, an anatomic side cut through a person just to show how far the tongue moves forward when you use a device. It's a device that a dentist makes, and the dentist takes a mold of your teeth and your bite, and then uses this to construct this plastic instrument with this little ratchet in here. It's like, those mouth guards people use for grinding. It's exactly like that at the top. It just has a bottom piece as well, which allows for allows for this to be used as a fulcrum to move the bottom jaw forward. And in doing so, if you move the bottom jaw forward, you move the tongue forward, and there's space to be had there so people can breathe well. It's not a bad way to fix sleep apnea, actually. It's not great for severe apnea, but it's pretty good for mild to moderate apnea. I prescribe them all the time, although probably far less than a CPAP machine. When you come to the lab, there are many things we're measuring, but the main thing we're measuring is airflow. So people most commonly have normal airflow. So you take a breath in and out, in and out, in and out regularly through the night. Okay. Sometimes you have what we call a central apnea, where you take a breath in and then there's no breath at all and there's no effort at all. See here, in conjunction with this breath in, there's a respiratory effort, so the chest is trying to breathe in. In this next diagram, there's a respiratory effort up here and here. But here there's no effort. Nothing's going on there. There's no airflow, but there's no effort either. Okay, that's called a central apnea. That often happens in people who are on narcotics or other medications. We sometimes see that in heart failure as well. So people who have really bad pulmonary hypertension could potentially get that. But the most common thing you're going to see is obstructive apnea. So what that means, and this is kind of relevant because if you ever watch someone with apnea, you'll notice this. There's no airflow. They're not breathing, but you can see their chest moving. So here you've got airflow and the chest moving. So that means there's air going through the nose into the chest, and the chest is moving, drawing it in. But here, the chest is trying to move, but there's no air. So the chest gives a bigger effort. There's no air. The chest gives a huge effort, and then air goes through. That's why when you're watching someone, you'll see them trying to get a breath in, and they can't, and all of a sudden they do. It can be quite scary to the spouse. This is very common. This is the main reason why patients get sit in. The spouses see this. So what we do in the lab is we add all those together. Stopping breathing 0 to 5 times an hour is normal. Surprisingly, it's not 0. 0 to 5 is normal. 5 to 15 is mild. Above 30 is severe. The way this looks in a sleep test when we accumulate all the data, you don't need to look at this in any detail, but just so you understand, we measure your stages of sleep up here. We measure the respiratory events. So here in this box, every little black mark is the person stopping breathing. Okay, that's a lot of them there. This is the oxygen level. And in this particular person who has profoundly severe apnea, their oxygen level trends down and tends to go really far down when they stop breathing. But you notice it seesaws back and up and down. That's because they're not stopping breathing continuously. They're stopping breathing, then they're breathing in. Then they're stopping, then they're breathing in. Every time they breathe in, their oxygen goes right back up to normal. Okay? There's nothing wrong with getting oxygen into the lung. The problem is the breathing tube is closed with obstructive sleep apnea. What we do is we take all of that data, we combine it into a report in which we add up the number of times they're stopping breathing. Okay. And in this particular case, it's a really high. I just brought this for a dramatic example. It's 164 times per hour. So that's a lot of stopping breathing. Remember, 30 was severe. So if we look at the diagram and how it looks here, it's very much many episodes stopping breathing and the oxygen goes down. And if I go to the next diagram here, this is a diagram where someone is put on a CPAP machine. And what you can see immediately is these apneas here all seem to disappear. There are a few of them, but there are very few. The oxygen is right up there at 90 or above 90% with very few dips. So what's essentially happened is the machine has pushed air in and kept the breathing tube open. The person breathes on their own. The machine doesn't help you breathe. It just keeps your breathing tube open. So you breathe on your own, and all of a sudden the oxygen comes right back up, and you're not stopping breathing. Interestingly, if you look in the stages of sleep here, in the first diagram that I showed you, there's this thing called REM, or rapid eye movement, or dream sleep. The person didn't have any. In the stages of sleep, it never kind of went down there, right? Which is normal with sleep apnea. They don't get much REM sleep, deep sleep. But once they're on the CPAP machine, you can see, oh my boy, they got a lot of dream sleep. There's tons of it. In fact, you could say more than half the night was in dream sleep. That's more than usual. Normally, it's about 15%. It's just that when dream sleep is suppressed by sleep apnea, the first night you take them, put them on a machine and eliminate sleep apnea, you get what's called REM rebound. It just comes back big time. Okay. So this is a very dramatic example of what sleep apnea is, how we assess it, and how it can be treated. It's very impressive and interesting. There are many physiological considerations that you might imagine how sleep apnea might in fact affect the heart. So we're going to go into a little bit of depth here, and I'm going to kind of just describe it in a way that someone without too much understanding of how the heart and lungs work would understand. But diagrams are always helpful, so I'm putting up some diagrams. So if we imagine this being the lungs, this is just a diagram representing the lung. The head is up here. You're breathing in through the lung here. The way our lungs work is by our chest wall moves out. When our chest wall moves out, it creates negative pressure in the chest. It's like almost like a vacuum, and that draws air in. The way we breathe, that's the way we breathe in. So our chest wall moves out, there's negative pressure in the chest, and air goes in. The way we breathe out is our chest wall goes in, our diaphragm comes up, and it pushes the air out. It's more passive when you breathe out. It's more active when you breathe in. That's why, if you just imagine yourself breathing in, you take a breath in, you could feel an effort to take the breath in. But when you let the breath go, you just relax. You're not doing anything. The air just automatically goes out, right? That means the chest was opening up to a position beyond where it normally is to draw the air in, and then it just relaxes to the closed position and air goes out. That's how it normally works. The problem is if you have sleep apnea and you have a limitation to the flow of air up in the throat, you need to really draw a lot of chest pressure out in order to get the air in. Okay? So because you're working so hard, you're not just straining the lungs to get the air in, the heart's in that chamber as well. The heart's in the chest. You're pulling the chest out to get the air in. And what that's doing is it's placing a force on all the structures in your chest, including the heart, pulling it out so it can't contract in as well. I'm exaggerating what goes on, but these are the general principles of what happens. So when you have an obstructive apnea where you're trying to take a big breath to get the air past the closure in your neck where your tongue is, the heart can't press in and pump the blood out because it needs to contract to press the blood out. The heart has a hard time doing that because it's being pulled out. So it can actually, it doesn't really cause any problems for the heart that minute or that night or that month. There's no difference in the short term. But if this happens over 10, 15 years, you could just imagine that heart had to work a lot harder than it would have otherwise had to work. That's why people with obstructive sleep apnea end up with heart-related issues. There are many aspects of the mechanics which result in increased effort of the heart, which we don't have to go into a lot of detail in. But the thing is, those problems result in the left side of the heart, left ventricle, which is pushing the blood to the body, having to work harder. Okay. When it works harder, it needs more oxygen. So it's not so great for the heart. It creates a lot. It's as though the heart is exercising, actually, if you think about it, during a time when the heart should be relaxing at night. This pattern results in the autonomic nervous system being more active, kind of like flight and fright. So if you see a snake right next to you, all of a sudden your blood pressure is going to go through the roof, your heart rate is going to go up, and you'll want to panic and run, right? It's a flight or flight response. That's almost, you're not even thinking. Your autonomic system is working there, right? So your sympathetic tone or adrenaline in your body is rising with all of these apnea. And this adrenaline rise is causing problems in your heart. It's making the blood vessels very stiff, so it's hard for the heart to pump. It's making the heart a bit twitchy. Okay, with a lot of adrenaline, everything gets a bit twitchy. In fact, they've done studies that show this is sort of a measure of the sympathetic tone, or you could think about it as adrenaline levels. So in the daytime, that sympathetic tone is not that high in daytime or in sleep. This is in sleep, actually. But when you have obstructive sleep apnea, you can see that sympathetic tone spike. So you get a lot more adrenaline and a lot more sympathetic tone like flight and fright when you have uncontrolled sleep apnea. It's as though you're running or something, right? The problem, if you have that one night or 1 month or a year, it doesn't really impact you that much. But if you have it for many years, there's this cumulative effect of high adrenaline levels, which is not good for the heart, high blood pressure, arrhythmias, so rhythm problems like atrial fibrillation, fast rhythm problems, heart failure, heart attacks, strokes. No risk in the short term, but a significant risk in the long term. In fact, the magnitude of the risk, which we'll talk about in a minute, is similar to smoking. It's not small. In addition, and this is kind of important for what we're talking about, you get nocturnal fluid shifts. So fluid shifts in your body nocturnally, like at night. If you imagine anyone, if you have pulmonary hypertension or anyone you know has pulmonary hypertension, you know that there's a tendency to retain fluid. We retain fluid for a number of reasons, part of which is because our heart is not working perfectly. And you'll know you see the fluid in your legs the least in the morning. And the reason why you don't see it in the morning is you're lying flat on the bed and fluid goes where gravity is. And when you're lying flat, it'll kind of go in your main trunk of your body. But if you've been on your legs all day, by the end of the day, you notice more edema or fluid in your lower limbs, like your feet, your calves, your lower leg. Okay. You press on it, it kind of divots down in people who retain fluid. This is not in anyone, right? Not in everyone. But what's interesting is if you have a lot of fluid there and you lie down, that fluid redistributes. So when you're lying down, your feet is not where gravity wants to take the fluid. It wants to kind of take it to your whole body near the bottom, and it'll go to the central trunk of your body. So fluid that was in your leg, some of it will be in your belly and chest, and some of it will be up near your neck. In fact, they've done very nice studies that show as the night progresses, there's a change in leg fluid volume. So the leg fluid volume in this scale on this, you can see it's going negative. So the leg fluid volume is decreasing as the night goes by. It's like the fluid's going away from the legs. And the neck circumference is increasing as the night goes by. What that means is the fluid is leaving the legs and redistributing, including around the neck, which makes apnea worse. So it's not simply that heart failure's bad. I mean, obstructive apnea can be bad for the heart. Heart failure can be bad for obstructive sleep apnea as well. Very interesting. So just briefly, obstructive sleep apnea can impact a number of cardiac diseases. There is 2 to 3 times the risk of high blood pressure if you have uncontrolled sleep apnea. 50 to 60% higher risk of coronary artery disease, almost a third higher risk of heart failure. And in atrial fibrillation, it's very common that someone would have obstructive sleep apnea. In fact, sometimes people go into an irregular rhythm that needs to be shocked out of. You really have to fix the sleep apnea before you do that. That's obstructive sleep apnea. That's the condition where your breathing tube closes off and you need to make a big effort to breathe in. But I had briefly mentioned there's something called central sleep apnea where your brain just doesn't tell your body to take the breath. That often happens in heart failure. It can happen in heart failure. It can happen in people who are on narcotics or people who have had a stroke. This is less of an issue than obstructive sleep apnea because there are less of those big efforts and swings. But even with central sleep apnea, where your brain's not telling your body to take a big breath, the oxygen can go down, and that's not great for the heart as well. So both obstructive sleep apnea and central sleep apnea can both affect the heart adversely. And heart problems such as heart failure can make obstructive and central sleep apnea worse. So the problems go both ways. It's not just in one direction. Well, what about something a bit closer to pulmonary hypertension? Because a lot of these things are related, but in pulmonary hypertension, it's particularly important to consider because if you remember that picture that I showed you, the cartoon of the heart in the chest, the thing to remember about pulmonary hypertension is it's the right side of the heart or the right ventricle that gets most impacted by these changes in forces. And the right ventricle, unlike the left side of the heart, is a thin-walled structure. So why is the right ventricle so thin? Well, the left side of the heart, its job is to pump blood to the body. And the body is at a very high pressure, 120 millimeters of mercury, right? When you take a blood pressure. So the left side of the heart's a big, strong, thick muscle that's used to pressing hard. The right side of the heart is used to pushing blood through the lungs. The lungs normally, in someone who doesn't have pulmonary hypertension, is a thin-walled structure. It's very thin. It normally pushes against a pressure of 12, 10 times less pressure. Now, in pulmonary hypertension, that's not exactly true. People have higher pressures in their lungs, and so the right ventricle will be a bit stronger, but it'll still be way weaker than the left side, which means if you have uncontrolled sleep apnea, it can affect how well your heart's working even more in someone who has pulmonary hypertension. This results in a number of changes in the right side of the heart, like the left. And you don't have to know the details of all these, but just in broad strokes, it affects the volume of how much is being pushed through, blood is being pushed through. It affects the manner in which the right side of the heart receives its own oxygenation. Okay, the muscle of the heart needs oxygen as well to function, and all those pressures reduce the effective oxygen of the muscle, which is not great for that heart. And it makes it really hard for the right side of the heart to fill and push the blood through the lungs, which causes more strain on the right side of the heart, which is already straining, trying to push blood through the lungs with pulmonary hypertension. What about in the pulmonary circulation? Well, the pulmonary circulation at rest has a very low resting tone. The tone of the muscles is relaxed. It's rest. Okay. With exercise, super interesting. If any of you are interested in exercise, when you exercise, your cardiac output increases dramatically. So a normal cardiac output might be 5 or 6 liters per minute, but with exercise, it'll go up to 25 or 30 liters per minute in a healthy individual who is fit. So it goes up 5 or 6 times or even more. Okay. And the way that happens is the heart pumps harder and it pumps faster. So it pumps harder and faster, and it can push 6 times the amount of blood. So what's super interesting is that blood goes through the body, and you can just imagine the muscles need the extra blood, but that entire volume of blood now needs to go through the lungs. So you would wonder, well, if you're normally pushing 5 liters per minute of blood through the lungs, when you exercise and it goes up to 5 times that or 6 times that, won't the pressure in the lungs increase? The answer is no, it doesn't increase. And the reason why it doesn't increase is the lung can recruit, there's a bunch of blood vessels in the lung that aren't even filled. They just open up and fill. So a normal person who exercises, even though there's 6 times the volume of blood going through the lung, their pulmonary pressures don't even go up. It's quite amazing, actually. So there's a lot of reserve capacity in the lung, a lot of which is lost when you have pulmonary hypertension. So you're just a little bit more susceptible to increases in pressure, particularly with exercise, which is one of the reasons why when people with pulmonary hypertension exercise, they feel very limited. When you get obstructive sleep apnea, you not only have closure of the airway, but your oxygen decreases, as we saw earlier in those pictures or those little cartoons. That leads to pulmonary vasoconstriction. That means the blood vessels become tight. That can result in the pulmonary vascular resistance, the PVR, increasing by 3 times. Okay, that's why it's not a good idea for a patient with pulmonary hypertension in general. That's really bad to go on a plane because the blood vessels get tight when there's low oxygen tension, when the oxygen is very low. But it's also a reason why when someone has obstructive sleep apnea and their oxygen goes down because they can't get the air in, the pressures in the lung can rise really high, and that puts more strain on the right side of the heart. There's another way in which sleep apnea affects the heart as well, and it can cause pulmonary hypertension. There's a type of pulmonary hypertension called group 2 or pulmonary venous hypertension, which essentially refers to problems on the left side of the heart, which are many related to aging and blood pressure. Those problems can become worse with obstructive sleep apnea. So as you get worse sleep apnea, you get increased sympathetic tone, that the adrenaline, that increases the resistance systemically, systemic vascular resistance, and you get systemic hypertension, high blood pressures in your blood vessels in your body. That leads to the left side of the heart becoming hypertrophied, so the muscles become strong, and you get what they call diastolic dysfunction, which is a medical condition which leads to pulmonary venous hypertension. What I've described there is a little bit complicated, but just so you understand, the obstructive sleep apnea leads to the blood vessels in the body being very stiff and tight, as though you have a high adrenaline level. That leads to high blood pressure and consequent high pulmonary hypertension. So there's many ways in which sleep apnea can cause hypertension. However, it's not really directly a cause for group 1 PAH. As everyone's listening here, we know there's many types of pulmonary hypertension, but group 1 PAH is very unique. The pathophysiology is quite unique. The response to medications, the histology, if you got a sample and looked under a microscope, is very unique. It doesn't exactly cause group 1 PAH. What it does is it worsens PAH. So when I see a patient who we've diagnosed with PAH, I don't worry that sleep apnea caused their PAH. The only thing I might worry is, could sleep apnea be worsening their PAH? Or could it be causing things like heart failure, which could worsen sleep apnea, if that makes sense there. In the context of all these factors, what we do is we use the CPAP machine. It's just that you have to use the CPAP machine with a little bit of care in someone who has heart failure, which is why I always do a sleep test in the sleep lab when I have someone with pulmonary hypertension, so the technicians can monitor the heart rate and the oxygen level of the person who has a heart condition. It's not as simple as a young 25-year-old who just needs a machine. I actually promised I was going to stop 2 times in between, and I got so excited about some of these topics, I completely forgot that. But we have plenty of time to chat about questions at the end. We're almost done. So just in summary, there are numerous effects of both obstructive and central sleep apnea on the heart. Mechanically, there are, just with those forces. Autonomically, with the autonomic nervous system causing high adrenaline levels, there is. And I didn't really go into the details, but when you have low oxygen, it causes a bit of an inflammatory response in the body, which can also affect the heart. Ultimately, positive pressure of some kind of a machine assists in controlling and eliminating the apnea, and that's the primary method of addressing this problem. Although you would, of course, try to optimize treatment of pulmonary hypertension, optimize your volume status by eliminating salt and minimizing fluid so you don't have a lot of excess fluid, because you saw from some of the pictograms I showed you that fluid redistributes over the course of the night. It's not a dramatic redistribution. It's more, it's less than you would imagine looking at the pictures, but it does occur. So controlling volume is very important as well. That this essentially, though, is going to be the focus from a sleep apnea perspective. Once that's all treated, you treat with positive pressure with one of those CPAP machines or BiPAP machines. I'm going to stop there. I think we have, it's been 45 minutes. We have exactly 15 minutes in order to review everything.
Great. There's one question so far in the chat. If anyone has any questions, you can pop them in the Q&A box and we will address them. Oh, they're coming in the chat as well. I'll try and keep track of both. So first off, someone asks, I don't have obstructive sleep apnea, but I don't exhale enough carbon dioxide, so I'm on a BiPAP machine. How does this affect pulmonary hypertension?
Yeah, so that's great. Great question. So just as just a general topic,
Yeah.
people can. There are all sorts of things that can be abnormal in terms of gas exchange when someone has any sleep-related problems, and there are different solutions for each problem. So it's not quite as simple as I made it out to be. It can be more complicated, and sometimes it takes a bit of fine-tuning to make things good. As long as the oxygen level is within normal limits on the machine, and the apnea is controlled. If someone does have apnea, their pulmonary hypertension will not be affected by it.
Okay, another question from the chat. How often should you go for a sleep study to check your obstructive sleep apnea if you have PAH, so if you have pulmonary arterial hypertension?
So it's not mandatory that you have to go for a sleep test. If someone had absolutely no symptoms, everything was going well, they're sleeping perfectly, they're not overweight, they don't need to go. If they're having sleep-related symptoms, even if they didn't have pulmonary hypertension, it would be reasonable to get a sleep test done. Um, the question, though, and that's just a general answer, but the question specifically was asking how often. You don't have to have repeated sleep tests unless something changed. Let's say you've had a sleep test and it shows that you don't have sleep apnea, unless you've gained a lot of weight or your sleep is worse for some reason. And by a lot of weight, I mean at least 20 pounds. You don't need to repeat a sleep test.
Okay, this is making me very sensitive about my own sleeping patterns, I have to say. Okay, another question. Can treating sleep apnea have negative effects on the body or worsen pulmonary hypertension?
What a great question. You should always ask, okay, what's the negative about, treatments, right? So if I just give you a broad view first, let's pretend you had someone who had obstructive sleep apnea but doesn't have heart failure of any kind. There are really no negative consequences of obstructive sleep apnea with the machine. It's just air from the room, pressurized to keep your airway open. As long as you're using filtered water to clean the machine, it should be really, really super safe. No issues at all. Probably treated 20,000 patients. Never had a patient with any complication in my career. However, heart failure is always different. Sometimes positive pressure and machines are not a good idea in heart failure. And the sleep specialist would know this because it is the right thing to try the machine. But if apnea gets worse on the machine, that means the way the heart dynamics are, that person is not able to tolerate positive pressure in terms of the pressure changes. So even though it looks like sleep apnea is a bad thing, it may be worse to be on the machine, which is why the first test when you have pulmonary hypertension should be done in the sleep lab. I mean, nothing dramatically worsens, but if your oxygen was a bit worse or the heart rate is a little bit, if something was concerning, if something was concerning or if the oxygen went down, then you have to think, is this the right answer for this patient? So it's not that it's dangerous or it's not that the machine is bad to treat obstructive sleep apnea. It's just that when you have heart failure, it's a way more complicated question. It's not necessarily just pulmonary hypertension, it's heart failure in general, including heart failure related to pulmonary hypertension. So the person needs to be tested in a lab the first time just to make sure that everything's okay. I mean, the truth is, I'm being very conservative by saying there. Some people get tested without knowing that they have pulmonary hypertension and everything worked perfectly well. And I acknowledge that, but that's probably not the best way to go about it.
Okay. Sort of a follow-up question to that one. Does elevating your head with a wedge pillow help people sleep better?
It does in terms of comfort, number one. Okay, in terms of a comfort issue. But I think you may be getting at well, if they feel more comfortable and they sleep better, then yes. But you may be getting at is can it help with sleep apnea? What I would suggest there is if I am sleeping and the wedge pillow is simply cranking my neck forward, then I'm not really advancing anything or improving the apnea. But if my wedge pillow is wedged under the bed and it's wedging my whole upper body up a little bit, or if I was in a hospital bed, one of those mechanical beds that you can get at home, motorized beds, not motorized bed, sounds like it's a bed on wheels. You know what I mean? Electric bed is what I was thinking about. That angles the whole body up. It takes weight off the back of the throat and improves things. Just to give you a illustrative example of that, if you sit up and 90 degrees in a chair, almost no one will have sleep apnea because the tongue comes forward away from the back of the throat. The more you lie flat on your back, the more apnea you get. So if the wedge pillow we're talking about moves the whole angle of the upper chest up, then yes. But if it just cranks the neck forward, then no.
Okay. I feel like I'm sleeping wrong now. Okay. It's a question from the Q&A. Somebody says, I am on oxygen at night. Would that oxygen help keep my airway open?
No, it will not. So the problem with sleep apnea, okay, let me give you an illustrative example. If someone had fibrosis of the lung, where the lung tissue is thickened, or emphysema, where smoking has damaged the lung, the problem is the air going into the lung can get in the lung, but your lung is damaged, so you can't extract oxygen into the blood. So a person in the scenario that I described would need supplemental extra oxygen to get oxygen into the lungs. And there are many reasons why you may need supplemental oxygen. With sleep apnea, the problem is the breathing tube is closed. So you could have 100% oxygen, but it just won't get past the breathing tube. So it doesn't fix the apnea. When the person takes a breath in, they'll take a breath in with lots of oxygen, but that's not the problem. The oxygen's not the problem. The problem is the breathing tube is closed.
Okay. Uh, when one's oxygen desaturates to the low 70s during a 6-minute walk test, would the heart be pumping deoxygenated blood, causing rapid breathing?
So, yeah, this is a complicated question. It's nothing related to sleep apnea, but just to give you a broad answer to this question, it is one of the most characteristic things in terms of oxygen with pulmonary hypertension to see someone desaturate on exertion. So, they're sitting in a chair, they're in the 90s, but they walk and they go into the 80s or 70s, right? It's not uncommon, it's common. Maybe less common to the low 70s, but it certainly goes down. Now, why does it go down? Well, it's complicated. There are many factors, one of which is the lung has less reserve. I had mentioned how when you exercise, lots of open blood vessels open up and accommodate that blood fluid. People don't have a lot of reserve like that with pulmonary hypertension because the lung slowly does get damaged by pulmonary hypertension. Number two, sometimes the amount of oxygen that our body needs is more than in another individual. So the oxygen that's desaturated that comes back to the lung from the body is even lower than a normal person's, and it's hard for the lung to quickly resaturate it. The bottom line is due to all those factors, the oxygen level in the blood will be lower. So it says, will the heart be pumping deoxygenated blood? I mean, in a sense, you're right. Essentially, it's the heart needs to pump the blood. And it's just the blood that it's pumping didn't get fully reoxygenated. The blood is definitely at a higher level, even if you're in the 70s, than it was when it got back to the lungs. Okay. But it's just not going to be where you want it.
Okay. Oh, here's another question. Besides the Darth Vader type masks you showed, are there other treatments available for those with obstructive sleep apnea or central sleep apnea? Are there medications? Are there other things that you can do?
Yeah, it's a great question. The problem is this is a mechanical obstruction in the vast majority of people. Central sleep apnea doesn't have a lot of great answers, just to be honest, but it is very rare, very rare. Obstructive sleep apnea is, let's say, 99% of cases. Central sleep apnea is 1%. So with obstructive sleep apnea, really, you need something to open up the airway. So it's either a mask, and it could be that very subtle mask under the nose. It doesn't have to be the big Darth Vader mask. There are tiny masks which keep the airway open. And yeah, so essentially you need that or a mandibular advancement device to pull the jaw forward, or things that I didn't really mention. Like you could get, it's very severe surgery. No one would do this, or very few people would, where they break the jaw, put a filler in, and move the jaw forward. But medications don't really fix this. There are kinds of apnea that you might imagine in the future will improve with medications, but not bad obstructive apnea.
Okay. Any last minute questions from anybody? We've got about 5 minutes left. Oh, here's another one. Somebody with pulmonary arterial hypertension who snores at night but is not at all overweight. Should they probably get tested for sleep apnea?
Yeah, it's a great question. 60% of adults snore, whereas less than half of those have any apnea. So even in the case of snoring, many people would not have apnea. I would say if they are noted to stop breathing in their sleep, they should definitely get tested. If they are just snoring and they feel perfectly fine, it's probably worth getting tested, but I wouldn't, put a rush on it or anything.
Okay. Any other questions from anybody? Counting down. Three, two, one. Okay, I think we will end there then. Thank you very much, Dr. Chandy, for your presentation and answering all our questions so clearly. Um, have a great day, everyone.